Thank you very much, David. I'm sorry my French is so poor. I will do this in English, but I hope you can follow my comments or my talk. So I was invited here, and thank you very much for this invitation. And the topic is, I think, very relevant when you are a cataract surgeon, when you are doing corneal transplantations. This combination of Fuchs endothelial dystrophy and cataract is something you meet every day. Which surgery to do when? Should you just do the cataract, or should you do a combination? So this publication is probably familiar to many of you. Professor Ernst Fuchs, presented this more than 100 years ago in the beginning. Everyone thought it was an epithelial dystrophy because, the techniques to examine the eye were not so advanced at that time. And what was obvious at a late stage, you would see edema of the epithelium. But that's actually not the main problem in this disease. So there are many definitions. I pick one here from Egrari, a few years old. He said that Fuchs corneal endothelial dystrophy is a bilateral, hereditary, progressive disease of the posterior cornea, which results in excrescences of Descemet's membrane, guttae or guttata, endothelial cell loss, corneal edema, and in late stages, bullous keratopathy. So that's one definition covering the whole spectrum of the disease. And I think how can Fuchs dystrophy give you trouble? As I said, every day before surgery, you see patients, or we at least do, that have, guttata, and they also have some cataract. And what to do? What will give the patient or what causes a significant impact on visual function? And the decision to be taken is, should we just do phaco, or should we do a triple procedure? During surgery, there can be issues due to poor visibility, but that, I think, can be handled almost always. And after surgery, you can have dissatisfied patients, depending on what you are doing. And we will get back to these topics. Now, guttata or guttae, how common are they? And there's actually not many studies on this, but I have a good colleague on Iceland, in Reykjavik, Gunnar Zoega, and he did his master or thesis on this topic some years ago, and looked upon the population in Reykjavik, looked on 774 participants just picked out of the population, and on Iceland it's very homogeneous. He picked the patients or subjects that were 55 years and older, and then he actually classified the inner side of the cornea and looked for guttae. And what he found was this: he could classify according to the pictures over here, where you have a normal endothelium, a single guttae, a bit more, and then even more, and covering a major area. But still, patients with prominent guttae coming into actually corneal dystrophy, they were excluded. So just guttae here, and you can see how many cells. They were able to count the cells between the guttae, and actually the cell number was pretty good, despite patients developed guttata. And he also measured the corneal thickness here, and it was actually normal throughout the range that he looked upon. And then he counted how many subjects actually had corneal guttata. He found that 11% of all females, 7% of all males had some kind of guttata. And he looked upon some associations. Higher weight, higher body mass index were associated with a decreased risk of corneal guttata. having smoked more than 20 years increased the risk of corneal guttata. And he didn't find any association with age-related macular degeneration. So that was the guttata that you can find it in approximately 10% of your patients if you look for it. But then how common is Fuchs endothelial dystrophy? Using the definition that actually this is something that affects the corneal thickness, and where you begin to consider doing posterior lamellar keratoplasty. So first of all, the presence of single guttata is not Fuchs according to the definition. And again, we have a definition here. Fuchs endothelial dystrophy develops from primary central corneal guttae, okay, and then leads to endothelial decompensation and corneal hydration. So progression to this stage merits the diagnosis of Fuchs endothelial dystrophy and signifies the overlap between these conditions. So it is like a range. Now, how common is Fuchs endothelial dystrophy then? And if you look into the literature, I don't think we know when you have patients with significant effects of your cornea with increased corneal hydration, etc. And I think also the definition depends somewhat on how good access to healthcare the patient have. I mean, the availability of corneal donor tissue, the surgical techniques you use, that will affect actually the how common Fuchs endothelial dystrophy is, at least to the extent where you actually treat it. We looked into this in Denmark, we have a corneal registry in Denmark together with Sweden, and this is just for Denmark. The blue here, that's the number of keratoplasties for Fuchs endothelial dystrophy in Aarhus, and the red, that's the number of operations at the hospital in Copenhagen. So we are only 2 centers in Denmark doing corneal transplantations actually. And we can see how it goes over the years, that there is an increase in Aarhus as well as in Copenhagen over the last 5 years or something like that. It has been pretty stable. And then you can begin to calculate a little and say, okay, 2 out of 10,000 subjects over 55 years, they will develop Fuchs endothelial dystrophy and have a corneal transplantation based on our small country. I mean, we are only 5.6 million. I think you are 10 times or a little more of this here in France. And we have a population of 1.8 million above 55 years. And then using these numbers, you can make a rough estimate of the prevalence of Fuchs endothelial dystrophy, something like 0.5% or something like that. So going down from these 10% of patients having guttata or guttae, you end up with 0.5% or maybe a bit more. That's the prevalence. So that was just a bit on Fuchs. And then before surgery, I mean, you look on the patients, you talk to them, and typically they develop symptoms in the 5th to 6th decade of life. And traditionally we ask the patients, I mean, this blurry vision, is it the same the whole day, or do you have is it more blurry in the morning and then it improves during the day? And we also ask, I mean, does it become worse over time? And actually, if they have pain and epithelial bullae, I mean, there are clear symptoms. Then we take a look in the slit lamp. We have the guttata here, and they are centrally. They were developed there in the beginning, and it can be difficult to take photographs. But then after that, it becomes more confluent, metal beaten inner side of the cornea, making the actually findings stronger, that this is something we have to do something about. And then finally, when the patients develop bullae, we understand that something should be done. So that was just looking with a slit lamp. Then We measure corneal thickness. You can do it the very old way, manual Hackstreit pachymetry. We still have that in our clinic, but we use pentacam, we use OCT to measure corneal thickness. Today it's much more precise. Ultrasound we use occasionally. So the corneal thickness will not increase much before endothelial cell density goes below 500. And that's also something to consider. So corneal thickness can be sort of normal for quite a long time. Then we measure or look upon all our patients referred for Fuchs endothelial dystrophy with our specular microscope. This is not the one we use here, just images for illustration. We have a non-contact specular microscope, which is not as good as a contact one. But you can see that there are dark elevated elements here, and the cells become larger, so endothelial cell density goes down. The problem is often that edema, if there is such, obstructs the specular microscopy in later stage endothelial dystrophy. So typically we say if we cannot see anything on the inner side of the cornea, that's also a strong indication for actually doing something for the patient. So what to do? Now the patient has cataract, we have the guttae, and there's a slightly increased corneal thickness. That's the typical situation. Should we just phaco and I will, or phaco, I will, plus DSEC or DMEC? So again, the classic approach is ask if this blurry vision has diurnal variation, look for the guttae, measure the corneal thickness. But I think everyone have realized this is probably not enough to distinguish between who will benefit and who will not benefit for having a endothelial graft. If you look upon just central corneal thickness, the American Society have some preferred practice recommendations, risk factors for decompensation. They have that as thickness above 640 micron. A Dutch study here, we will get back to that, corneal thickness more than 630, and another recent study, thickness above 645. And if you look upon that only, the thickness, you will have very poor sensitivity, but quite high specificity, meaning that some patients actually have problems that can be removed if you do a corneal transplantation. Okay, then advanced approaches. You can look with the confocal microscope or a pentacam, and that has been done here in Holland. Van Klee and Bruegel published 2014. They looked upon 89 patients. They had Fuchs endothelial dystrophy to some extent, and they had cataract. And all patients to a start only underwent cataract surgery, and then they followed the patient. And who were happy and who were not happy, was there an indication to do endothelial keratoplasty, and it was approximately 30-40% that actually needed keratoplasty. And they measured a lot of parameters before surgery and then looked which of these or how many parameters actually predicted that patients needed endothelial keratoplasty. And they found, after a lot of analysis, that okay, central corneal thickness, it was a significant factor, but also findings in confocal microscopy, this epithelial valley, that you have some backscatter from the anterior part of the cornea. But doing confocal microscopy on all the patients coming with Fuchs it's a little hard work to do that, so I'm not sure it has become that popular. But then we have a study here from Italy. They almost did the same kind of study, included 84 eyes with Fuchs, and these eyes all underwent phaco. They also had cataract, of course, and they did some preoperative measurements, best corrected visual acuity, thickness, anterior chamber depth, corneal backscatter, and again found that only 40% that of these patients with Fuchs and cataract actually needed endothelial keratoplasty after phaco. And what they looked upon was mainly pentacam pictures. They looked upon the backscatter here in the anterior part of the cornea, and it's tiny numbers here, but an increase in the backscatter, a bit similar to this epithelial valley the Dutch group found. That was important. And they also looked upon how the thickness is over here, central corneal thickness, but they also looked upon a thickness profile. So normally we have a thinner cornea in the center, and they found that if the cornea more or less had the same thickness all over, or actually was a bit thicker in the periphery compared to the thicker in the center compared to the periphery, that was also an indication. And also if the thinnest point in the corneal thickness was not in the center. So they used these things and said, now we have a risk model to predict the later need for endothelial keratoplasty. The US group here, led by Sanjay Patel at Mayo Clinic, published this. Again, it was something, they didn't do surgery, they just characterized patients with Goutte, and they put them in 3 groups. Clinically definite edema, you could see it in the slit lamp. Subclinical edema, based on tomographic, again, pentacam features without clinically definite edema. Again, it's something with, you have a focal area here of posterior surface depression, meaning that the central corner becomes thicker, and also irregular isopatches of the corneal thickness, and a displacement of the thinnest point of the cornea. So this classification is independent again of CCT and should be considered when evaluating Fuchs patients for cataract surgery or endothelial keratoplasty. But what is needed is a randomized controlled study to actually see if this is something we can use in our daily clinic. So, okay, now we have sort of decided more or less what to do. We discussed cataract surgery, the disadvantages. If the patient develops edema, there will be a prolonged time for final visual recovery, because we often wait 3 months after cataract surgery to see if endothelial keratoplasty is needed. The advantage is, of course, that EK may not be necessary. If we do the triple procedure, the disadvantages, there can be graft dislocation, rejection, and maybe if it is a younger patient, and young, it depends on your own age. So young today is when you are younger than my age, 62. So, life expectancy, in Denmark, they assume that patients, all people are going to be 100 years old, and that means you have to regraft them several times. The advantage is, of course, 1, surgery, avoid corneal and scarring caused by edema. If you have a long-lasting edema that is not taken care of, you can have a bit of permanent haze. So, but most important, I think, inform the patient about the pros and cons of doing what you want to do, and talk about expectations. Prepare the patient, if you only do cataract, that it may be necessary to do a transplantation later on. A little thing worth to consider if you, when you do the IOL power calculation is, after a DSEC procedure, the posterior surface becomes steeper because, first of all, the edema resolves, and you have a bit thicker graft thickness here in the periphery when you do DSEC. And actually, what about the anterior surface? Does it change? It's something worth to consider. We did a study also a few years ago and found that, okay, the posterior K reading actually changes 0.7 diopters. It's a negative valence here on the back surface of the cornea. You have to take that into account when you do combined surgery, but it was a bit surprising that also the anterior K reading changed, so the cornea became actually a bit flatter after DSEK or DMAC. So I think take that into account when you do the surgery. It's probably 1 to 1.5 diopters in DSEK, 0.5 diopters in DMAC, because here you don't change the posterior surface curvature quite much. So aim for a bit more myopia. We also looked upon asphericity and could not find an influence of that. So that was if we decide to go for the triple procedure. What about during surgery? I mean, experienced surgeon, yes, and be cautious. Of course, we should always be cautious when we do cataract surgery. And you can consider to do the soft shell technique where you use a cohesive and a dispersive viscoelastic. What about visibility during surgery? Epithelial edema, if there is such, obstructs the surgeon's view. It can be the edema itself. Also, if you use povidone iodine, it actually stains edematous cells. And if it is a problem for visibility, you can just remove the epithelium at the beginning of surgery. It will, of course, take a few days to heal, but it improves visibility a lot. In the triple procedure, if you're going for that, we use aspheric IOL, and we do a normal phaco. Maybe some suggest make a capsulorhexis that is a bit smaller to make the IOL stay in the capsule when you do the manipulation afterwards. Maybe constrict the pupil after the procedure. We actually don't do that, but it's some recommends that it should be done if you do the DMAC. Okay, the surgery is shown here. Just summary, I'm not going to show any moves. I think you can know how to do the procedures. We did DSEK. We started in 2006, and then we actually have done like 1,500 DSEK procedures, and we're quite happy with that procedure. But over the last 5-6 years, we have transited into doing DMAC in almost all cases. And we use actually the endothelial in technique and an injector. It was introduced to us by Marc Morin here from France, and we are happy with that, and that's our preferred surgical technique. Now, what should we do, sequential or triple DMAC? I mean, if we decide that we are going to do cataract surgery, going to do endothelial keratoplasty, is it better to do it sequential or at the same time? There's a study here from, again, published in the American Journal of Ophthalmology, but it's a retrospective study, single institution, and they had like 34 eyes, pseudophakic and DMAC only, and 80 eyes underwent triple DMAC. And they found actually that a combined triple DMAC procedure resulted in significantly greater loss of endothelial cells than the DMAC-only procedure. I think this needs to be confirmed in a proper study perspective. Okay, what should we do? I think we still miss randomized prospective controlled trials of how to best handle patients with Fuchs and cataract. That is definitely needed. After surgery, what to do there? I mean, patients can become dissatisfied, especially patients where you decided to choose just cataract. They have some edema. They don't get an improvement in visual acuity. I think we repeat again the preoperative talk and say, remember, we talked about this. And of course, you should not. Wow, it went a little too fast here. Anyway, I can do it without. So after surgery, don't do same-day surgery, right, in patients with Fuchs dystrophy and cataract, because then you can end up with a patient that has poor vision in both eyes, and you have to do DMAC in both eyes over some time. And again, patient counseling is the most important thing. And just for a conclusion, to say that talk to the patient and be be aware that there can be problems associated with Fuchs dystrophy and cataract surgery. I think our tendency is that we do the triple procedure quite often, and then we think maybe it is a little too often, then we do a sequential procedure, and then sometimes it works, sometimes it does not work. So with these words, I would like to thank you all for inviting me, and have a nice meeting here.
Merci beaucoup. Thank you so much. It was wonderful. Now it's a pleasure to serve you.
On behalf of the French Society and SAFIR, we are very pleased to give you this certificate of appreciation and gratitude for your contribution, and also the medal of our 140th anniversary.
Micro, just to repeat.
Just in appreciation of your contribution and the gratitude for your outstanding presentation, we have prepared this certificate, and together with the medal celebrating our 140th anniversary of the French Society. Thank you very much.
Thank you very much.